Okay. All right. Thanks for inviting me to talk today. My name's Kyle Chapman. I'm a pulmonologist here in West Virginia. I did my training at WVU and I never left. So, one of the things that I'm really excited about is talking about lung cancer screening. So, again, thank you for this opportunity. My hope is that through this talk, we generate some good discussion and uh, with without further ado, I'll go ahead and get started. So the focus here is mostly going to be lung cancer screening in West Virginia and some of the surrounding regions. As far as disclosures go, I have no relevant financial disclosures. I get some grant support from the Cystic Fibrosis Foundation, but it doesn't really touch on lung cancer screening. The basic breakdown of what I want to talk about is kind of a timeline. So talk a little bit about the past of where we've been with lung cancer and why that's such an issue. What can we do to prevent disease, and then talk about the present in our current practice, all the issues we have referring folks for lung cancer screening, and then talk a little bit about my vision for the future as well. So, like next slide. All right. So thinking about the past and the problem of lung cancer in Appalachia. So how bad is it? This is a terrible problem, right? So lung cancer is not the most common cancer, but it's up there. So it's second to prostate cancer in men and second only to breast cancer in women. But despite being less common than either of those, there are more folks in West Virginia that die from lung cancer than breast cancer, prostate cancer, colon cancer combined in a given year. So it is the most common cause of cancer mortality in the Mountain State. And the number here, the statistic is the 5-year survival is only 28%. So while that's a very sobering number, 5 years ago, that number was a 5-year survival of 21%. So there are some reasons to have a little bit of optimism in this talk. If you think about on a nationwide sense, right, anyone can get lung cancer that has a set of lungs. So uh, there's always talk about when you think about lung cancer, you don't want to exclude people that have never smoked, right? Because they can still get lung cancer due to other exposures or just genetic makeup or what have you. However, in West Virginia, almost 90% of all of our lung cancer cases are directly linked to tobacco smoke, either personal smoking history or significant secondhand exposure. So that'll be the focus today is about tobacco-related lung cancers would primarily be what I'll talk about. All right, next slide. So how bad is it in West Virginia? So this is an area where we are unfortunately leading the country. We have the highest rate per capita of smoking across all 50 states. And really, it's like neck and neck with Kentucky. So Kentucky has more cases per 100,000 people per year than we do, but we're number 2 in the country for cases of lung cancer. And looking at our outcomes for those folks that are diagnosed with lung cancer, we're in the worst 1/5 of all the states. So the graphic here comes from the American Lung Association. So this is part of the challenge behind dealing with lung cancer. You can see at the top, what's the stage of the diagnosis? And in West Virginia, nearly half of all of our cases are diagnosed when they're already at a metastatic state, which is what's represented in the bar graph by green. And then if you look at the 5-year survival below that, for someone diagnosed with a stage 4 cancer, their 5-year survival is only 8%. So the idea is with lung cancer screening, if we're able to detect cases of lung cancer in the population before they're symptomatic and before it's spread, then their outcomes are going to be a lot better. We can potentially cure them with surgery or radiation, and we have a lot better treatment modalities. So the idea is we're going to shift the time of diagnosis to earlier, and we have seen that over the past 5 years. So our rate of early detection is better than what it used to be, although it's still not good. I might have an animation on this slide. You hit next, does another graphic come up? All right, hit it again. All right, and for the chat box, is the sound doing a little bit better or still cutting out? All right, so this is a graphic collected from the Department of Health and Human Resources by the state of West Virginia. So they do a cancer report every so often. So this is like a 5-year average of 2015 through 2019 data. And it correlates pretty strongly with what the American Lung Association data is tracking, where nearly half of the cases are diagnosed at advanced stage. So next slide. All right, so how do we tackle finding lung cancer? So prior to the 2010s, we didn't have a good screening modality, right? These are patients where different, primary care providers thought, hey, maybe we'll send sputum for cytology, or we'll check a chest x-ray in the office, or we'll think about some other biomarker or blood test. But none of those ever really panned out. So there's also an important concept I like to talk about called pulmonary reserve. So we have a lot of lung function, and it's frankly more than we need for going about day-to-day life. So the problem there is you can have a tumor occupying in one lung, and it may not cause a lot of symptoms. So this can be in the early stages a disease that does not have a lot of symptoms, and it's really only when it spreads or becomes so metabolically active that they start losing weight, having night sweats, or it's like eroding through an airway or into the chest wall, that it really drives a lot of symptoms. So early on, because of the concept of pulmonary reserve, patients may go undiagnosed. So what happened in the 2010s, there was a big screening trial called the National Lung Screening Trial. And they looked at, all right, what happens if we follow at-risk patients that were enrolled in the study with an annual CAT scan? And what they found was they diagnosed a lot of cancer in that group. Their control group that they compared it to was folks that were getting an annual chest x-ray, which also did diagnose cancers, but by the time they were found on chest x-ray, they tended to be at a more advanced state. So based on their findings, they said there's a huge reduction in cancer mortality if we can enroll patients in screening, where we do a once a year annual screening CT with low dose radiation. The 20% decrease in mortality was the US data. That study was published like 2011. And then within a couple of years, the United States Preventive Service Task Force said, hey, lung cancer screening is something that we need to start offering. And then subsequently insurance started covering it. So it has been around for over a decade, but there's been some challenges with the uptake so far. One of the things that a lot of people were concerned about early on was this, if you do a CAT scan, you're looking for lung cancer, but what do you do with everything else that you find that's not lung cancer? And so there has to be a good support infrastructure for all these incidental findings as well. All right, next slide. So this led to the original guidelines based on the National Lung Screening Trial. And they said, okay, if a patient is 55 to 80 and they've smoked for at least 30 pack years, and they either currently smoke or quit within the last 15 years, and they would want treatment for a cancer if it was found, this is who we should screen. So just to make it extra confusing, this is a lot of things, but right, you have to know the smoking history, total pack years, time that they stopped smoking, and they need to be willing to undergo the treatment. So I think some of the nuance around the eligibility made it kind of intimidating, right? It's not straightforward like say colonoscopy or mammography, where it's just everyone over a certain age is going to get screened for this particular cancer, right? So then just to make it more confusing, after that data had been out for a while, they said a lot of people are getting cancer between age 50 and 55, and a lot of people, especially women and African Americans, can get cancer with a lesser smoking history. So this seems like it's kind of heavily weighted for Caucasian males. And so they changed it and said, okay, 20 pack years now qualifies you for screening, and you can start screening at age 50. So that change was made in 2021, but even in our cancer center, we had a hard time with the rollout because we said we want to be up to date. We want to offer screening to these eligible folks, but insurance took a while to get there. Now most insurance does cover lung cancer screening with the expanded criteria, but then there's some funny insurances where they say, hey, we want to stop screening at age 77 because that's who was in the original trial. But the United States Preventive Service Task Force says 50 to 80, 20 pack years, either current smoker or former smoker within the last 15 years. So who was excluded from the screening group? People that quit more than 15 years ago, the thought process was they still have some risk, but their risk compared to the general population is not that high. So if we screened in these folks, it's less likely to be beneficial. if they had active symptoms of a lung cancer, you wouldn't screen them. Like you would expedite that workup. You wouldn't just refer them for annual screening. And then if they had such bad other comorbidities that they wouldn't be willing to undergo treatment for their cancer, they really shouldn't have been included in screening at that point either. All right. Any questions about this? Because I know it is a little convoluted with the eligibility.
I just have a quick question, sir. Did you say that it is more prevalent in African Americans? Could you repeat that, what you said? I'm sorry.
Yeah. So the initial criteria was felt to be a little bit discriminatory. So what they found in real world data looking at diagnosis of lung cancer was they found that that people of African American ancestry were more likely at higher risk of developing a cancer prior to age 55, and they could do so. The risk seemed to be there even with a lesser smoking history. So when they made this expansion in 2021, it was thought to be a more inclusive thing and more equitable screening parameters. All right.
Thank you. I appreciate that.
All right. There's also been an argument made, okay, instead of investing a lot of money into this infrastructure for screening and doing annual CAT scans, what if we just pumped a lot of our resources and focused on getting people to quit smoking? And absolutely, that is true. But there's some problems with that logic as well. So the absolute best way to make an impact on decreasing lung cancer burden in West Virginia and across the United States is to enable these folks to get off of cigarettes, to stop smoking. So absolutely, that's true. But I think we know from all of the money against like that big tobacco has paid out and funding different government programs to help with tobacco cessation. That's a good idea, but in practice, it doesn't work. And this is an area where West Virginia has lagged behind. Even when we can give away free nicotine replacement products, we still have the #1 rate of tobacco use. So tobacco cessation is very important, but we are still improving cancer mortality through screening as well. A couple of differences between the original study group of the National Lung Screening Trial and the population that I take care of here in West Virginia. So that study was done primarily out of New England. A much higher percentage of their patients were former smokers as opposed to current smokers. And then their total lifetime exposure to cigarettes was a lot less than our average in Appalachia. So that being said, all of the benefit there is we still have a benefit, but if anything, the benefit in West Virginia is actually maybe a little bit higher than the benefit was in New England. So every lung cancer screening program should be partnered with the tobacco cessation program as well. All right, next slide. All right, another important facet that I acknowledge is there are other risk factors for cancer, right? So if you've never picked up a cigarette, you can still develop lung cancer. But that risk, again, in West Virginia is primarily driven by cigarette smoking. Radon is the #2 risk factor for lung cancer. As on a state level as a whole, we're actually about average for radon exposure. I think the challenge is here, we never think about radon, right? It's a colorless, odorless gas. And other than when I bought a house 7 years ago, I've never like paid for a radon inspection. You can have like radon detection kits. Our West Virginia Department of Health and Human Resources has promoted it as like a free thing.
Yeah.
For people that are interested in screening for it, but we just don't think about it very often, right? The next bullet point, occupational risk.
I'll see if any other guys can.
Exposure to diesel exhaust, silica dust, asbestos. All of these are common in West Virginia, so these are risks too. And then if a patient has had prior chest radiation or a strong family history of lung cancer, I acknowledge these are major risks of lung cancer as well. All right, so that was kind of the past of where we've been with lung cancer, why it's a bad disease, and some of the challenge in diagnosing it early. Now we'll talk more about the present and what we're trying to do with lung cancer screening. So,
hey Kyle, there was a question in the chat asking about veterans that have been in like combat
okay. Yeah, I can see the chat. I'll address that. So right now, the lung cancer screening criteria are limited just to tobacco exposure. So there's not a specific criteria for military veterans, but yes, that environmental exposure is significant and does increase the risk of lung cancer. So there is a separate society called the National Comprehensive Cancer Care Network, and they have a separate screening criteria for lung cancer that takes into account some of these secondary risk factors, like I had on the previous slide, and definitely around a lot of diesel exhaust and other things that you might see in a combat environment. They can be significant risks, but they're not currently part of lung cancer screening as our what we can get insurance to pay for. Good question. All right, so it's still a challenge for us. You can see that even though we're getting to the diagnosis earlier in some cases, the real problem is we're not getting the right people in to be screened. And what I mean by that is there is a lot of data out there that says people that smoke are less likely to engage in primary care, like preventive medicine, and much less likely to undergo screening. So I think I've had some quality improvement efforts where I've focused on improving access for people that are already seen at primary care, and there's some room for improvement there, like make no mistake. But I think the bigger issue is, and yeah, I'll talk about mobile screening too. But the bigger issue is a lot of these folks just aren't coming to the doctor or the healthcare provider to be seen. And so I think there's a very large unreached population. So even though we're screening only about 5%, West Virginia is actually in the dead center of the country on this. So we are very average. Most states are right around 5%, not much better than that. Even in where they did the National Lung Screening Trial in the state of Massachusetts is currently the best state for screening, and they only screen about 20% of all eligible people. I can also talk a little bit about having trained in West Virginia and grew up here in the Mountain State. I think sometimes there's a challenging kind of mindset that we have to overcome. I've seen this a lot as a pulmonologist, but I can speak to even my own grandfather, where he would say, don't take me out of the holler into a hospital unless I'm going there to die. So like the idea of doing something to prevent disease and catch it early can be challenging to sell to some of our patients. All right, next slide. So looking at why is the uptake so poor? I mentioned we were only screening about 5% of eligible patients. With that in mind, I'll address the incidental findings too. With that in mind, I did a survey a couple years ago now with primary care docs in the Morgantown area, seeing, okay, what is kind of the mindset around lung cancer screening, and then specifically what are some barriers and how can we address that? So I had about 50 responders, mostly attending physicians, and this was about, do you feel like it's on your shoulders? Is this your responsibility to recommend your patients for screening? And the majority said, yeah, it is something we should be recommending. As far as the incidental findings like idiopathic pulmonary fibrosis, other interstitial abnormalities or finding of emphysema, do you think that there was an unacceptable number of comorbidities to manage that you find when you do a CAT scan? I was surprised by that one too. The majority said, I don't think there's too many false positives. This question that the bar graph is showing here is how many scans did you order in the past year? And this was really enlightening to me. So we had a couple super users that were ordering 50 or more scans, but you see the majority of folks were only doing less than 5 screenings a year, and several were saying that they weren't doing any. Next slide. So for this question, they were allowed to have multiple selections, and it was anything that they identified as, hey, this is a barrier keeping my patients from getting in for lung cancer screening. And so these were the ones that stood out to me. So questions about, is this something insurance will cover? Is there a lot of steps to go through with prior authorization? Nearly a quarter of respondents said that, yes, that was a problem. Transportation issues, another quarter said, yes, that's an issue. Maybe the patient's already coming an hour to see their provider, and now you want to do a test that they'll have to come back for. Interestingly, about 1/5 of the responders said, if there was something really annoying that we could embed in the electronic medical record to remind us, that might help. But up to 20% said they'd never even tried. And then the last bullet point, lack of comfort with the results, confusion about PAC years or eligibility or benefits of screening. No one really seemed to say that that was like a major barrier for them. All right, next slide. So things that we've done at West Virginia University to help with this. So one is, what if we put some patient empowerment out there and just let patients that are interested, maybe they're not even a patient, maybe they're just out there in the community, maybe we can have a pathway directly. So we run ads, we put up billboards, we also do some things on social media like targeted ads and advertising, and we have this option where they can self-refer. So if they're interested, they submit a little questionnaire, and then we will call them, do a telephone visit where we'll do the prior auth and order the screening scan. We do that. Honestly, the return on investment there has been kind of modest. On average, we may get like a dozen or so folks through this pathway in a given year. We also do some screening fairs. So we'll have, if there's like a health fair in the community, we've gone to a couple of those and had a table, and we may get some people interested there as well. This is a poster that's a little bit dated. So this was a screening event we did back in 2020 or 2021. So, so we've done some advertisement trying to enable people to get the information and do it by on their own. We've also done some work around provider education. So I go around, I've given lectures to family medicine, internal medicine, residents and faculty. I'm speaking here today to talk about lung cancer screening. So we really try to do a lot of education to make sure that people know how beneficial this can be. We try to help with coordination of care. Within our health system, we have an option where if you order a low-dose CT scan, there will be a pop-up that says, do you want to make this as easy as possible and refer them to our nurse practitioner clinic? And then our nurse practitioner will do everything after that, order the scan, document everything to make sure that it gets authorized, and then also help with adherence. So I will take a quick break to answer a couple of the questions here in the chat box. Number one, do we have mobile screening units? Yeah, I'm going to talk about our program there. And that's one of the things that we're doing that's really exciting. How do we deal with findings like other things from screening that are non-cancer? So this is a bit of a complicated answer. So from our screening program, we will say, hey, if this is here and it's a non-malignant finding, we're going to communicate those results both to the patient and the ordering provider, usually a community PCP. And then if the patient is interested, we're always happy to see them in the pulmonary clinic as well, but we don't default to that. We don't want to step on anyone's toes, right? If you're taking care of this patient and managing things and you order a study, we don't want them necessarily plugged in for something we weren't specifically screening for. So we offer it, but we don't necessarily like automatically schedule a follow-up just for like emphysema that we're finding. And then I apologize, the poster is a graphic from a couple of years ago. And then Luann says, yep, Medicare has been a big stickler for stopping at 77. Yeah, that's been the challenge. All right, so I'll talk a little bit more back to the slides about our screening programs and what we're able to do. So we have a traditional screening program. This is a map showing where patients have come from by zip code to be screened at our Morgantown site. So we have a facility-based site. We have scanners in Ruby Memorial Hospital as well as up at the University Town Center. And then we recently added a site in Fairmont, and then we collaborate with a couple of other sites as well. So we oversee some of the work being done at Wheeling Hospital, Reynolds Hospital. We are also affiliated with the Summersville site, which is also spread out and has a site in Braxton County too. The benefits of this program, again, this is the one that's run through WVU Medicine here at our Cancer Institute, is we have a dedicated nurse navigator and we have a nurse practitioner too. So we have great adherence rates. One of the other challenges with lung cancer screening is that adherence to coming back year after year for continued screening. When they rolled this program out, unfortunately what we've seen nationwide is that the annual adherence rate is well below 50%. So someone maybe comes in, they get a screening, they say, they didn't find any cancer, I'm good, I'm not going to go back for another scan in a year. Our adherence rate at WVU is north of 90%. And part of it is because we have this centralized program. Our nurse navigator will often be there at the University Town Center site. When a patient comes in for screening, she'll say, hey, why don't we go ahead and schedule for your next follow-up a year from now and like get it on the books. We send out reminders when it's getting close to time. Hey, you have your upcoming appointment. by mail, by phone, etc. Also on MyChart, the patient portal. With our centralized approach, which I admit is resource intensive, we are really good at getting insurance to cover it. So if the patient's eligible, we're going to document everything that shows that they meet eligibility criteria and get it covered by insurance. We've also tried to standardize across all of WVU medicine. If a patient is uninsured, but they want to be screened, there's a one consistent cost, no matter which site they're going to, for out-of-pocket fee. And it's not cheap, but it's like, I think it's around like low $200 for a one-time screen, if they want to do out-of-pocket. Some of the great things about this program are we meet regularly to look at how many folks are we screening, what are the outcomes of the screening results, and we grow the program year after year. So even adding on all of these sites, we've had continued growth even through the COVID-19 pandemic. So it's been a really successful program in a lot of ways. All right, next slide. I'll talk now about our mobile screening program, which kind of goes hand in hand. So someone asked if we had mobile screening. We were the first in the world to do mobile screening the way we do. So this is our Lucas unit, which stands for lung cancer screening. We are the only fully mobile lung cancer screening program. We were the very first. There were a couple of earlier iterations of this elsewhere, but they were dependent on external power, so they were limited to where they could go. With Lucas, we can go anywhere where we have a level surface to park. This is one part of it, so it's really more of a train than a bus. So this is our 18-wheeler. There's obviously a commercial driver's guy with the CDL that goes with it. We also have a CT technician that goes with it. There's a second unit that follows behind the big rig. That's a pickup truck with a generator. So we have our own power source. And because of that, we're able to go really just about anywhere in the state. We launched in 2021. And our idea was that we would be a prototype for other cancer centers. And since that time, we've met with over 30 different cancer centers, including some international cancer centers that have said, how did you build Lucas? How did you do it successfully? And is this something we can imitate? So in West Virginia, a lot of our folks are living in a rural area, and if they have to take off time from work and drive hours just to get a screening scan, they probably weren't going to do it. And that's been our experience when we're out in the communities. Lots of people say this was so convenient, it's right next door, and that's why they're able to do it. But really the success of our mobile program was predicated on community engagement. So we have an existing mammography program called Bonnie's Bus that had been around for a while. So when we came up with Lucas, the idea was we would engage with different practices throughout the state, and we would say, you already use this for Bonnie's Bus. Lucas is the next generation. Now we're looking at screening in a mobile setting for lung cancer. If a clinic is interested, we will then send out an advanced team. We'll go over some information about here's the eligibility criteria, here's the benefit. And then if that group practice has, say, at least a dozen people that they think will be interested, we'll schedule a day and bring the rig down. All right, next slide. So with mobile screening in particular, we really address a lot of these issues. We bring the screening to them, which is significantly more convenient. We work with insurance, so most of the time we'll get the scans covered by insurance. But because of generous philanthropic support, if someone doesn't have insurance, we're able, and they meet eligibility, we're able to do it for free. So we address the insurance and the prior auth. When we do find a patient with some positive results and they need something, we don't necessarily say, okay, now come to WVU Medicine, right? Our goal here is just serving the population. If there's a good thoracic surgeon or pulmonologist closer to home, we say, hey, here's the closest hospital. We'll help you get an appointment there if you need to be seen. But luckily, the majority of folks that undergo screening, the recommendation is going to be continued screening on an annual basis. And guess what? Lucas will be back in your community 6 months, 12 months later, so we can definitely manage that. All right, next slide. This is a map of the counties where we were able to go for Lucas. So that the counties where we're able to go are in blue. The counties in white, when we did our certificate of need, had existing lung cancer screening programs. So some of those health systems asked us not to step on their toes and set up mobile screening if they already had a facility in the county. So we can go to any of the ones in blue. Some of the ones in blue have added screening sites since we started, but for convenience sake, we still go to a lot of these counties. All right, next slide. So what happens when we read a lung cancer screening scan? It should be interpreted by thoracic radiology using these specific criteria called lung RADs. So you'll see the majority of folks are going to be lung RADs 1 or 2, where it's a benign appearing scan, no evidence of cancer. That's going to be 90% of folks, and they should just get a continued screening each year, assuming that they continue to meet eligibility criteria. So that's 90% of folks. Then looking at lung RADs 3, the majority of these are going to be benign as well, but there's something there like a nodule greater than 6 millimeters or something has changed, and so you want a little bit sooner follow-up. So for these folks, we do a 6-month scan. If they're lung RADs 3 and above, we will notify them with a letter and also usually a phone call. If they seem like they have a lot of questions or they're worried about it, we can even see them in the clinic. We'll offer them a clinic visit for lung RADs 3. All right, next slide. Or next graphic. Yeah, next. If it's lung RADs 4, so 4 is subdivided 4A, 4B, 4X. These are folks that we want to see in the clinic. A lot of them maybe end up being a non-malignant process, but here we're going to need closer follow-up, like within 3 months and maybe even a biopsy. So for these, we offer them a clinic visit and try to see them ASAP. All right, the turnaround time from when they are screened to the provider receiving the report depends on the medium that we're communicating in. So we will find out when the radiologist reads it, usually within the week. And then if they're on our electronic medical record, we will notify the provider immediately. If they are outside of our system and referring into it, that'll be a little bit more manpower. We will mail a letter immediately, but we will also call. All right, next slide. All right, so, and then to Dr. Wertz's question, literature on screening occupational exposures like silica. Not in this primary setting where we're looking at asymptomatic patients. So certainly the occupational exposure does increase the risk of malignancy, but that's not part of these screening guidelines. So the NCCN that I mentioned earlier does say, if this is a factor, you should think about screening them. The challenge is getting insurance to pay for it. So in the setting of a pulmonary clinic, I can usually justify saying, okay, I need a CAT scan for X, Y, or Z, and that'll give me some information. But as far as like getting it year after year, that would be really challenging. All right, I'll talk a little bit about the future here. So lung cancer screening, hopefully I've kind of covered why there are some challenges there. And again, to me, the biggest issue is not getting enough folks in to be screened. But then there was this really interesting study in 2022 called the Deluge study, and I'll talk briefly about it. But the idea here was that they had a huge cohort in the Mississippi Delta region of 22,000 patients that they followed over time. And in addition to lung cancer screening, they had 2 other cohorts. So one cohort was patients that were sick and symptomatic, and they referred them for acute workup for likely lung cancer. That's the thoracic oncology arm. But then they had a third arm of patients with no symptoms, but they came into the emergency department at some point. They had a scan and a pulmonary nodule was found, unrelated to the reason they went there. They were able to follow these patients over time and get serial imaging, and the results were really shocking. So next slide. So what they found was, I'll kind of walk through these graphs, but they actually found way more people were being followed up in this incidental lung nodule program. So again, maybe they didn't have a screening indication, right? Maybe they didn't smoke, maybe they're too young, maybe they're too old. But look, they enrolled 15,000 people over this time. So they really outpaced who was being enrolled in lung cancer screening. If you look at group B, we'll say, okay, how many of these patients were diagnosed with lung cancer? Not surprisingly, the ones that were acutely symptomatic, they're referred to a cancer center, diagnosed a lot of cancer. But this is where it got really interesting, is they actually said a lot of these incidental nodules had some suspicious features. When we did an additional workup, we found actually we diagnosed a ton of cancer, way more than we were finding from lung cancer screening. If you look down at letter C, you see the percentage of those patients that are found to have an early stage lung cancer, which is the whole point of lung cancer screening, the incidental nodule group outperformed them there too. So based on this, over half of the patients in the nodule group were never even going to be eligible for lung cancer screening. And even if they had been in a lung cancer screening, the lung nodule program still would have found 20% of all cancer diagnoses in this cohort. The next slide. The basic takeaway from this is Dr. Osarajaban, who we invited to come speak at our cancer conference last summer. He was the lead author on the study. That year, he was at the National Lung Cancer Roundtable, which is in Washington, D.C., and he presented his research. And essentially the challenge was everyone that's doing lung cancer screening should also have a pathway for these incidental pulmonary nodules to be followed. And so that's our plan here at West Virginia, is we want to use machine learning to pull out the data that already exists in our system and our EMR, follow these patients over time, and build out a clinic so some of these patients could have early stage of lung cancer. Right now, the kind of pathway is, okay, I'll talk about the emergency department again. So you come in, you're in a car wreck, they do a full body trauma scan. That emergency doctor is not thinking about this like 1 centimeter nodule, right? He's going through the scan, saying, is there an aortic dissection? How many bones are broken? That sort of thing. Same thing for the trauma surgeon. They're probably not going to pay attention to this. And over 90% of the time, that's where it stops. When the final radiology report comes in and says, hey, there's this nodule, recommend a follow-up scan in 6 months or a year, that patient may be out of the health system and never seen again. So over 90% of the time, we're missing those patients. They're not coming back to be seen by thoracic surgery or pulmonology. The idea is we could use AI to help us find these patients and track them better over time so that we can move that stage of diagnosis earlier in conjunction with lung cancer screening. All right, next slide. So I mentioned, again, one of our challenges has to do with these shifting guidelines. Medicaid still not screening above age 77. And then in 2023, the American Cancer Society said, hey, if you've ever smoked 20 pack years, it doesn't matter when you quit, you still have this increased risk of lung cancer. So they're saying everyone that's ever smoked should be screened. And then, as I mentioned, the National Cancer Comprehensive Cancer Care Network says, hey, there are a lot of other risk factors that we're ignoring as well. So the main challenge, I think, at this point in 2024 is that we're not screening enough people, but the adherence question is also significant. All right, next slide. So other areas that I think are promising for the future, there's a lot of research interest in looking at what we have now with low-dose CAT scans is imperfect. So what if we had something that was a little bit more specific, like a serum blood test or even an exhaled breath test, where we could correlate that with biomarkers for lung cancer. Some of the promising changes is we have much better ability to sample small pulmonary nodules. So I do a procedure called robotic bronchoscopy. That's, you know, when I went through my fellowship, I would have said that's science fiction. But now we're able to get further out into the lung and sample smaller lesions. The surgical techniques are also significantly better. So it used to be, if we referred someone for lung resection surgery, this was a huge surgery. They'd be in the hospital at least a week. Now it can be done minimally invasive, also with a robotic platform. They can spare the lung instead of doing an entire lobectomy. They can do an anatomic segmentectomy. And some folks are only in the hospital for 2 or 3 days after having lung cancer surgery. We also have a lot of evolution in what we're able to do as far as treatment of cancer. We look a lot more at mutation status now. So we have some options with immunotherapy with less systemic toxicity. And then for early stage lung cancer, you can use stereotactic body radiotherapy. So focal radiation is non-inferior to surgical resection. So if you have someone and they're a terrible surgical candidate, even with the modern technique, you can treat it with radiation and still have good outcomes. So the future of what we're able to do as far as treatment continues to improve. And I think 10 years from now, it'll be unrecognizable. All right, next slide. All right, I'm going to stop and allow for questions. All right,